Look like the flu. That was the first thing her daughter said when they arrived at the hospital. She had the flu, I thought. Fever since yesterday, body aches, no appetite. We figured it was just a virus. And it was a reasonable explanation. It made sense. Maggie, 74 years old, sharp, independent, had spent the day before lying in bed, turning down food, running a low-grade fever. The kind of number that makes you think, take something for it, get some rest, you'll be fine by morning. That's what she did. By Thursday morning, the fever had crept up a little. She ate almost nothing at lunch, drank less water than she should have, slept through the afternoon. Her daughter offered to take her to urgent care. Maggie waved her off. I'll be fine. It'll pass. That phrase. I think about it every time I see a case like this. It'll pass. By Friday morning, it hadn't passed. It had changed. Notice how much the details matter. And in medicine, change is the word that changes everything. When her daughter walked into the bedroom that Friday morning, Maggie was awake. She responded when called. But something was off, and it wasn't the kind of off you can easily name. The words coming out of her mouth weren't quite right. She looked around the room like she wasn't entirely sure where she was. She called her daughter by her aunt's name, a woman who had passed away 11 years ago. And when she tried to sit up in bed, she needed help, not because she was weak, but because the space around her didn't seem to make sense to her anymore. It wasn't the tiredness of a bad night's sleep. It was something else entirely. I want to tell you what was happening inside Maggie's body. I want to show you the 3 signs that were there from the very beginning, the ones that are so easy to miss. And by the end of this, you'll understand why confusion and fever together should never be brushed aside, and exactly what to do if you ever find yourself in this situation. Because this isn't rare. And knowing what to look for can make all the difference. The first thing I notice when I hear a story like this is the speed of the change. Not a gradual decline. Not the kind of slow worsening you can track day by day where you think, okay, she's a little worse than yesterday, let's keep an eye on it. This was overnight. Wednesday she had a fever and felt tired. Friday morning she didn't know where she was. That shift, that break in the pattern, is the first clue. And it's also the easiest one to explain away. Because we're wired to find familiar explanations. He slept badly. The fever wore her out. She's in her 70s, sometimes they get like this. We fit what we're seeing into something we already know because the unknown is harder to sit with than the familiar. But sudden confusion that appears out of nowhere alongside a fever, is not exhaustion. It's the brain signaling that something in the body has gone off balance. The first clue. A sudden, unexplained change in behavior and attention. Maggie wasn't forgetting things the way someone with dementia forgets. Slowly, over months, in a pattern you learn to recognize. She was disoriented right now. She didn't know the day. She called her daughter the wrong name. She looked at familiar objects like they were strange. One moment she seemed present. The next she was somewhere far away. This pattern has a name. It's called delirium, and I'll explain exactly what that means in a moment. For now, what matters is this. Delirium is not a mental illness, it's not a stroke, it's not the beginning of dementia. It's a signal. A signal that the brain is being affected by something happening elsewhere in the body, and that something needs to be found. Medical literature describes this pattern consistently. In older adults, an infection that seems minor can show up first as confusion, before any other obvious sign of severity appears. It's counterintuitive. It's exactly the kind of thing that catches people off guard when they don't know to look for it. The second clue was in Maggie's body in a way her daughter noticed but couldn't quite name. When she helped her mother sit up in bed that morning, she realized her breathing was different. Not gasping, not wheezing, just faster than usual. More shallow. Like her body was working a little harder than it should just to breathe. And she was drowsy in a way that felt wrong. Not the sleepiness of someone resting. This was a heaviness that resisted. You'd call her name, she'd open her eyes for a moment, and then they'd drift closed again. Like staying awake required an effort she no longer had. The second clue. Faster than normal breathing and a drowsiness that wasn't sleep. These two signs together carry real clinical weight. Breathing that's faster than usual, what medical professionals call tachypnea, which simply means an elevated breathing rate, can indicate that the body is trying to compensate for something. An infection that has spread beyond its starting point. An inflammatory response that has gone further than expected. A system working at its limit. Guidelines and medical reviews describe this combination. fever, altered consciousness, and rapid breathing, as a pattern that warrants immediate attention. Not a sign that the worst has already happened. A sign that the body is asking to be evaluated before it does. And the deep drowsiness, different from ordinary tiredness, belongs in that same category of concern. When someone with a fever can't stay awake, responds with a delay, seems like they're existing just slightly below the surface of things, that's not the body resting. That's the nervous system being affected. Maggie's daughter was a practical woman. Not the type to panic easily. But when she helped her mother walk to the bathroom and watched her reach up and hold her own head in both hands, a gesture she had never seen before, something shifted in her stomach. "Mom, what is it?" "It hurts. Back here. Really bad. A headache. Severe. At the base of the skull, radiating into the neck. Different from any headache Maggie had ever described before." And when her daughter, almost instinctively, gently tested whether her mother could tuck her chin down toward her chest, a movement so simple we never think about it, Maggie resisted. Her neck was stiff. Not paralyzed, but locked, like moving it caused pain. The third clue, an intense, different kind of headache and a stiff neck. That was the moment her daughter stopped hesitating and called 911. And it was exactly the right call. Because neck stiffness, that difficulty flexing the neck without pain, combined with fever and confusion, forms a triad that healthcare professionals recognize immediately. It appears in emergency guidelines around the world. It doesn't automatically mean the worst-case scenario, but it means evaluation cannot wait. Maggie's body was lighting up every warning signal at once. And now it was time to understand what was actually happening inside her. The paramedics arrived in 9 minutes. Her daughter had unlocked the front door before she even heard the sirens. She was standing on the porch, barefoot, phone in hand, wearing that particular mix of relief and dread that comes when you've finally asked for help but don't yet know what you're about to hear. The team moved quickly and methodically. They checked Maggie's vital signs. Her blood pressure was lower than her normal. Her heart rate was elevated. Her temperature had climbed to 102.5 degrees Fahrenheit. Her oxygen saturation, the amount of oxygen being carried in her blood, was sitting at the lower edge of acceptable. No single number was catastrophic on its own. But the picture they formed together said something important. In under 20 minutes, Maggie was in the ambulance. Her daughter held her hand until the doors closed. At the emergency room, the physician who evaluated Maggie asked a question her daughter hadn't expected. "Has she had any kind of infection recently? A UTI, anything respiratory, any wound?" Her daughter thought for a moment. And then she remembered. About 4 days earlier, her mother had mentioned some burning when she urinated. She'd been drinking extra water, figured it would clear up on its own. Never went to the doctor. Never had it checked. She did, actually. She thought it was nothing. The physician didn't say anything in that moment. But I can tell you what was likely going through her mind, because it's what goes through the mind of any healthcare professional looking at this particular picture. An untreated urinary tract infection. 4 days. A 74-year-old woman. Fever. Confusion. Rapid breathing. Dropping blood pressure. Elevated heart rate. The danger had never been the fever. The danger was what the fever had been signaling all along. I need to pause here and explain what was happening inside Maggie's body, because this is exactly the understanding that could make a difference for someone you love. When an infection starts somewhere in the body, in the bladder, in the lungs, in a wound, the immune system responds. It sends defense cells, triggers inflammation, tries to contain the problem locally. Most of the time it succeeds. The fever is part of that process. The body raising its temperature to make the environment harder for microorganisms to survive. But in some cases, and this is well documented in medical literature, the immune system's response stops being contained. Instead of staying focused on the infection site, it spreads. The entire organism enters a state of excessive alert, releasing inflammatory substances that begin to affect not just the infection itself, but the organs, the blood vessels, the circulation. This process has a name: sepsis. And I want to explain what that actually means, not in the alarming way the word sometimes lands, but in a way that helps you understand it. Sepsis is not a disease in itself. It's a response. It's the body reacting to an infection so intensely that it begins to cause damage in the process. The WHO and the CDC both classify sepsis as a medical emergency, not because it's always fatal, but because the time between recognition and treatment has a measurable real impact on outcomes. And the brain, in this scenario, is one of the first organs to signal that something has gone wrong. Because the brain is extraordinarily sensitive. It needs a constant, uninterrupted supply of well-oxygenated blood, glucose, and precise chemical balance in the environment surrounding its cells. When blood pressure drops, when inflammation spreads, when toxic substances produced by the infection reach the bloodstream, the brain feels it before any other organ shows visible signs of distress. And when the brain feels it, it shows. In the most visible way it can. Confusion. Disorientation. Words coming out wrong. A drowsiness that isn't sleep. What Maggie's daughter read as "she's just worn out from the fever" was in fact her mother's brain sending a distress signal. But there was one more layer to this case. And it was what made the emergency physician order tests with an urgency that left no room for waiting. The neck stiffness. The severe headache concentrated at the back of the skull. The high fever. The confusion. This specific combination raises another possibility, one that needs to be ruled out quickly. Because beyond sepsis, there are situations where infection doesn't simply spread through the bloodstream, but reaches the structures that surround the brain directly. Meningitis, inflammation of the membranes that protect the brain and spinal cord, and encephalitis, inflammation of the brain tissue itself, can both begin with fever and general malaise that seems unremarkable. And they can progress within hours. I'm not saying that's what Maggie had. I'm telling you what the physician needed to rule out before anything else. Because in situations like this, treating for the worst and finding out it wasn't necessary is infinitely better than the alternative. The tests were ordered immediately. Blood work, inflammatory markers, blood cultures to check whether bacteria had entered the bloodstream, urinalysis, imaging. And there was a careful clinical decision about whether to collect cerebrospinal fluid, the fluid that surrounds the brain and spinal cord, which can help identify infections in the meninges. That decision belongs entirely to the medical team, based on the full clinical picture. I mention it only so you understand the kind of reasoning that happens in these situations. What the first results showed confirmed what the clinical picture had already suggested. There was an infection. There was an intense inflammatory response. And the most likely origin was that urinary tract infection, the one that 4 days earlier had seemed like nothing. The turn wasn't in the test results. The turn was in what that infection had quietly been doing while no one was paying attention. There's something that stayed with me when I first started understanding cases like this one. We have a very clear picture of what a medical emergency looks like. It's dramatic. It's chest pain, it's a fall, it's someone collapsing in front of you. An emergency has a face. It has a moment you can point to and say, that's when it started. But some of the most serious conditions that exist don't arrive that way. They arrive as a fever, as tiredness, as that, probably just a virus, we say almost automatically. And they settle in quietly underneath everything until the body can no longer keep up the appearance that everything is fine. Maggie's case is one of those. And to understand what happened to her, not just the story but the biology behind it, I want to take you inside what happens when an infection stops being contained. It all starts with bacteria in the wrong place. In her case, almost certainly in the bladder. A urinary tract infection, a UTI, is one of the most common infections there is, particularly in women and in older adults. Most of the time it stays local. It causes burning, urgency, discomfort. It's treated with antibiotics and it resolves. But when it goes untreated, or when the immune system is less efficient than it once was, as can happen with age or with other underlying health conditions, the bacteria can find a path into the bloodstream. And when that happens, everything changes. When bacteria enter the bloodstream, the immune system receives a maximum level alert. It responds with everything it has. It releases inflammatory substances, activates defense cells, raises the body's temperature to slow the spread of the microorganisms. All of this is part of a response designed to protect. The problem is when that response becomes disproportionate. Instead of containing the infection and then pulling back, the inflammatory system stays in overdrive. The substances it releases begin to affect the blood vessels, making them more permeable, less efficient at maintaining pressure. The heart works harder to compensate. The organs begin receiving less blood than they need. And the brain, which depends on a precise and constant flow, begins to function differently. This is what medical literature describes as sepsis. Not the infection itself, but the body's response to it. A response that, when dysregulated, can cause dysfunction in organs that have nothing to do with where the infection originally started. The WHO classifies sepsis as a global health emergency. The CDC describes it as a leading cause of death in hospitals across the United States. Not because it's always fatal, it isn't. But because the time between recognition and response changes outcomes in ways that are real and measurable. Now the brain. I said earlier that the brain is sensitive. But I want you to understand why. Because it explains what happened to Maggie in a way that makes complete sense. The brain makes up roughly 2% of body weight, but it consumes somewhere around 20% of all the oxygen the body uses. It is the most metabolically demanding organ we have. And to function properly, it needs 3 things without interruption: oxygen, glucose, and precise chemical balance in the environment surrounding its nerve cells. When sepsis compromises circulation, when blood pressure drops, when blood vessels become dysfunctional, when inflammatory substances flood the bloodstream, the brain is one of the first to feel it. Not because it's fragile, but because it's the organ most dependent on stable conditions to operate. The result of that disruption has a clinical name: delirium. And I want to take the edge off that word because it carries more weight than it should. Delirium is not a psychiatric condition. It's not dementia. It's not permanent damage to the brain. It is an acute dysfunction, meaning it appears suddenly, in the way the brain processes information. The person becomes disoriented in time and space. Attention becomes unstable, present one moment, gone the next. There may be agitation or there may be the opposite. A deep drowsiness, a slowness that looks almost like absence. Speech can come out confused, memories from different periods of life can surface together. Guidelines and reviews published in journals including the BMJ and the New England Journal of Medicine describe delirium as one of the most common and most under-recognized presentations in hospitalized older adults, particularly when the underlying cause is an infection or an acute medical condition. Under-recognized because it's easy to misread. Easy to attribute to exhaustion, to the fever, to age. And in older adults specifically, delirium can be the only early sign of a serious infection. Before the fever climbs significantly, before blood pressure drops, before any of the more recognizable warning signs appear. It is the brain warning first. Now I need to talk about the other possibility the physician needed to consider. The one that explained the urgency behind every test she ordered, and the careful attention to that stiff neck. Meningitis is the inflammation of the meninges, the 3 layers of membrane that envelop and protect the brain and spinal cord. When bacteria or viruses manage to reach those structures, the inflammatory process that follows can be rapid and intense. The classic signs that guidelines around the world teach clinicians to recognize are exactly what Maggie was showing. Fever, a severe and unusual headache, neck stiffness, that inability to flex the neck without pain, an altered level of consciousness. Not just any headache. The kind patients describe as the worst of their life, coming on fast, hitting hard at the back of the head and into the neck. Different from anything they've felt before. And not just any stiffness. The kind that prevents a simple movement, trying to bring the chin down toward the chest, because it causes pain. These signs together, in the context of fever and confusion, are what NHS and NICE guidelines classify as red flags requiring emergency evaluation. Without delay. Without waiting one more day to see what happens. There is one more sign I need to mention. Not because it appeared in Maggie's case, but because it's too important to leave out. In some forms of bacterial meningitis, particularly meningococcal disease, a rash can develop on the skin, small reddish or purple spots that do not fade when you press a clear glass against them. This sign, which clinicians call petechiae or purpura, is an absolute emergency. If it appears alongside fever, you don't wait. You go to the emergency room immediately. Her results pointed to sepsis of urinary origin. The bladder infection that had gone untreated found its way into the bloodstream and triggered an inflammatory response intense enough to affect her circulation and, as a consequence, her brain. The neck stiffness and the severe headache raised the possibility of meningitis, which needed to be carefully investigated. The medical team evaluated, ordered the necessary tests, and made the decisions her condition required. I won't tell you it was straightforward. I won't tell you it was fast. But I will tell you what made the difference. Her daughter recognized that what she was seeing was no longer the flu. She didn't wait one more day. She called. And that was the moment that changed everything. I want this part to stay with you. Not just Maggie's story. I'll finish telling you what happened to her in a moment. But the practical side. What to watch for. What not to dismiss. Because this kind of situation doesn't only happen in hospitals. It doesn't only happen to older adults. And it doesn't come with a clear announcement. It arrives as a fever. As body aches. As, it'll probably pass. And the difference between catching it early and catching it late can be enormous. So let's talk about this carefully. When a fever is just a fever, and when it isn't. Fever on its own is an immune response. It's the body working. Most of the time in younger and otherwise healthy adults, a fever that comes with body aches, fatigue, and a runny nose will resolve on its own within a few days. With rest, fluids, and if needed, a fever reducer as directed by a healthcare provider. But there are situations where the fever isn't alone. Where it's just the surface of something deeper. And what changes the picture isn't necessarily how high the temperature climbs. It's what comes along with it. Think about it this way. Maggie's body temperature on Wednesday was barely above normal. A number almost no one would take seriously. But 2 days later, with the same process quietly advancing, she didn't know where she was. The fever wasn't the problem. It was the signal that there was one. The signs that cannot wait. I want to be direct here because clarity matters. If you are with someone who has a fever, any fever, and you notice any of the following, don't wait and watch. Seek emergency medical care or call 911. Confusion that appears suddenly. The person doesn't know where they are, doesn't recognize who's with them, says things that don't make sense, mixes up the present with the distant past. Especially if this is new. If yesterday they were fine and today they are not. Drowsiness that isn't sleep. The kind where they can't stay awake, where they respond slowly when you call their name, where holding a conversation takes more effort than they have. A heaviness that feels deeper than ordinary tiredness. Breathing that's faster than normal. More rapid than the situation calls for, more shallow with visible effort. It doesn't have to look dramatic. It can be just that quiet, persistent acceleration that doesn't fit. A headache that's severe and different. Especially one that comes on fast, hits hard from the start, concentrates at the back of the head and into the neck. Different from any headache this person has had before. Neck stiffness. Ask the person to try bringing their chin down toward their chest. If they can't do that movement without pain, if the neck feels locked, that is a warning sign. A rash on the skin. Small red or purple spots or patches that do not disappear when you press a clear drinking glass firmly against them. If this appears alongside fever, this is an immediate emergency. Do not wait. Low blood pressure or sudden dizziness. A feeling of near fainting, sudden pallor, cold hands and feet alongside a high fever. Rapid and visible worsening. When you check on the person hour by hour and they are clearly worse. Not a feeling but a real and measurable decline. Seizure. Any seizure in the context of fever in an adult requires urgent evaluation. A specific word about older adults. I need to say this clearly because it may be the most important thing in this video. In adults over 65, particularly those living with other health conditions such as diabetes, heart disease, or who take multiple medications, the body often doesn't signal a serious infection the way we expect it to. The fever may be low, or absent entirely. Pain may not be prominent. The classic signs we've learned to recognize can be muted, quiet, easy to overlook. And what shows up first is exactly what showed up with Maggie. The confusion, the disorientation, the shift in behavior. Medical guidelines and reviews are consistent on this. In older adults, any acute change in mental status, any sudden, unexplained shift in the way a person thinks, responds, or behaves, should be treated as a warning sign until proven otherwise. It is not a personality quirk. It is not just aging. It is the body communicating what it can. If you have an older family member, hold on to this. A sudden change in behavior alongside a fever, even a mild one, deserves same-day medical evaluation. Not tomorrow. The same day. What to do while you wait for help. The number that matters. In the United States, 911. Available 24 hours a day, 7 days a week. It's there for exactly this. Urgent care centers are an option for situations that need attention but aren't actively deteriorating. But when any of the signs I've described are present, go to the emergency room. If you're unsure whether something is urgent or an emergency, and any of those warning signs are there, choose emergency. Every time. Back to Maggie. She was hospitalized for 8 days. She received intravenous antibiotics, delivered directly into the bloodstream, reaching therapeutic levels faster and more reliably than any oral medication could, along with blood pressure support, fluid resuscitation and continuous monitoring of her vital signs and organ function. The possibility of meningitis was carefully investigated. In her case, the results pointed to sepsis of urinary origin without involvement of the meninges, but the correct clinical reasoning required that possibility to be ruled out before anything else moved forward. The confusion lifted slowly. Over the first several days, moments of clarity became longer, more stable. On the 4th day, she recognized her daughter without hesitation. On the 6th, she asked about her granddaughter. On the 8th day, she went home. It wasn't an instant recovery. It took weeks for the fatigue to fully lift, for her appetite to return, for her to feel like herself again. That's a common trajectory after a presentation like hers. The body needs time to reorganize what was disrupted. But she went home. And that wasn't guaranteed. On the morning her daughter found her staring at the ceiling, not knowing where she was. There's something Maggie's daughter said afterward, or at least it's the kind of thing I hear in situations like this and it stays with you. I almost didn't call. I kept thinking, am I overreacting? Am I making this into something it isn't? That hesitation. That fear of seeming dramatic, of making a fuss, of pulling the alarm for something that might just be the flu. I understand that. I really do. We grow up hearing that we need to push through, that fever passes, that you don't run to the ER for every little thing. And that logic makes sense most of the time because most of the time it really does pass. The fever breaks. The virus clears. The body handles it. The problem is that from home, without tests, without an evaluation, there is no way to know which time is the one that won't resolve on its own. And that is exactly why warning signs exist. Not to keep you in a permanent state of anxiety. To give you a compass. To tell you, up to here you can watch. After this point you act. Maggie eventually went back to picking up her granddaughter from school. Not right away, it took time as I said. The body needed weeks to recover from what it had been through. But she went back. With that calm, unhurried way she had of doing everything. Her daughter said she never let another UTI go unevaluated after that. A small change. With consequences that couldn't be more significant. Before I go, I want you to leave with 3 things from this video. The first, fever with sudden confusion, unusual drowsiness and faster than normal breathing is not just exhaustion. It is a warning sign, especially in older adults. The second, a stiff neck, a severe and unusual headache, purple spots on the skin that don't fade under pressure. These signs alongside fever are an emergency. Don't observe. Hope. The third, you don't need to know the diagnosis to act. You need to recognize that something has changed. That the person in front of you is not who they were yesterday. That the decline is real and it's happening fast. That is enough to seek help. The rest is for the medical team. If this video made you think of someone, a parent, a neighbor, someone you care for or who cares for you, share it with them. This kind of information reaches the people who need it most when we pass it along. And if you've ever been in a situation like this one, or know someone who has, tell me in the comments. It doesn't have to be a dramatic story. It can be the time you hesitated and went anyway, or hesitated and didn't, and what happened after. I read everything. And every story that comes through reminds me why this channel exists. Main sources: WHO, CDC, NHS, NICE and peer-reviewed articles. All links are in the description below. This content is educational, based on clinical guidelines and patterns described in the medical literature. It does not replace professional medical evaluation. Thank you for watching. Subscribe for more diagnostic file mystery stories.